I'm Dr. Susan Hodgson, lecturer at the MRC PhE Centre for Environment and Health at Imperial College London. Our study design looked at the protective effects of smoke-free legislation on birth outcomes, and for this work we used a quasi-experimental study design, Regression Discontinuity. England introduced a law to make virtually all enclosed public spaces and workspaces smoke-free on the 1st of July 2007, and using our regression discontinuity design, we analysed the short-term effects of smoke-free legislation on birth outcomes. A key feature of regression discontinuity is the focus on comparing outcomes in a short time interval before and after the intervention was introduced. And by using these short time windows, we can assume that unobserved factors are unlikely to confound the relationship between the exposure and the outcome, which aids causal inference. The parameter of interest is the effect of the policy on, in this case, birth outcomes in the different windows before and after the 1st of July 2007, the year the intervention was introduced, relative to that before and after the 1st of July in previous and subsequent years. The data we used comprised 1.8 million pregnancies resulting in singleton live births in England delivered between the 1st of January 2005 and the 31st of December 2009, which were extracted from the Hospital Episode Statistics maternity data. Using our regression discontinuity approach, we found that when looking at time windows of between 1 and 5 months following the introduction of the smoke-free legislation, and for those entering their third trimester, the risk of low birth weight, very low birth weight, preterm birth, and small for gestational age all decreased. Furthermore, our large dataset allowed us to show the impact of smoke-free legislation varied by maternal age, deprivation, ethnicity, and region. There are, of course, limitations to this study. We were reliant on Hospital Episode Statistics maternity data because we needed information on gestational age. However, these data represent only 58% of eligible births over the study period. There were also additional missing data on deprivation and ethnicity, and unfortunately no information on maternal smoking. Also, despite having a very large data set, once we'd stratified by maternal age, deprivation, ethnicity, and government region, our effect estimates were more uncertain due to reduced statistical power. Despite these limitations, our quasi-experimental approach provides clear and crucial evidence showing the reduction in adverse birth outcomes due to the implementation of smoke-free legislation.